Forward to the cloud. All right. Hello, everyone. Welcome back to another Monday, Rafael Medina, subspecialty episode. The focus of the session today is clinical reasoning, and we have two absolute legends in clinical reasoning who are going to make the session happen today. And my name is Maddie. I'm going to be facilitating the session. So the case discussant is Dr. Gurpreet Dhaliwal, who I imagine most of the people here knows because he really is probably the inspiration behind the creation of CP solvers in the first place. But Dr. Gurpreet Dhaliwal, so he's a clinician educator and professor of medicine at UCSF, where he teaches residents and students at the SFVA and in various settings. And as I mentioned, he is a true role model and inspiration to so many people interested in diagnostic reasoning, including myself. And CP Solvers truly would not be what it is today, or may not even exist if it weren't for you. So Gurpreet, thank you so much for taking the time to be here. And I'm really excited to learn from you. And if I can, one question that I just wanted to ask you before I introduce Kirtan is that, for people listening, whether they're residents or students who want to improve their clinical reasoning skills, what is any piece of advice you would give to them or a habit you would recommend that they focus on developing?
Yeah, first of all, Maddie, thank you for that introduction. I know there's a chatter of legends. I would say everyone who shows up at this and does extra clinical reasoning is a legend in my mind, and I'm honored to be surrounded by so many of them. And I think maybe that is my only advice, that if it's a skill you would want to get better at, whatever it is, you would look for as many opportunities as possible to practice it. And again, showing up at an event like this is a testament. I view this in the exact same way. For me, in some ways, like this is learning, this is teaching, and this is practice. And I'm very grateful that I get all three of them in an hour.
Awesome. Well, we have another legend in clinical reasoning who will be presenting the case to Gurpreet, and that is the one and only Kirtan Patolia. So he is a CP Solvers team member and is a current PGY2 resident at Cook County in Chicago. So Kirtan, would love for you to unmute, share how you're doing, and maybe share, a lot of people know you, but maybe share just a brief insight into why you love clinical reasoning and diagnosis.
Yeah, thanks, Mary, for the introduction. And firstly, I wanted to thank everybody for joining this session and to Dr. Dhaliwal for making the time out of his busy schedule. So I just wanted to say that, how starstruck I am right now. Like it's like easy to say that, oh, I am feeling excitement, but you cannot believe like I'm having palpitations right now. And I am fortunate enough to have met Dr. Dhaliwal once in person and have seen numerous clinical reasoning sessions online. And just 2 days ago, like he was at ACP, I was talking to Mary behind the scenes that I saw him presenting and discussing the two cases as Stump the Professor session in ACP. And you could see that it's like a celebrity, like people are swarming around him. I'm sure people are asking for autographs and stuff. So I know it's kind of a fantasy from our side, but like I cannot even imagine how it might be from the other side. It's kind of like, Taylor Swift of internal medicine kind of stuff. So it's like so cool and like so inspirational at the same time. So I'm like so fortunate to get an opportunity to present the case today. And today's case is like really special. I have saved it for the special occasion, and the story behind the case is also equally gripping. So hope that we can extract the maximum learning out of this case, and it will be a great session.
Amazing. Well, Gurpreet, we won't ask you to sing. Just ask you to discuss the case.
I saw some. Well, first of all, Kirtan that is very kind. He is both a great friend. He has come and visited me here in this very office, and we enjoy our time together. He's also a formidable opponent in the CPS arena, as I've watched him many times. I saw someone, I don't know about the Taylor Swift analogy. I saw someone put the Eros tour in the chat, and I think in our world, Eros means something totally different than the way that she and her crew pronounce it. The Swifties do.
Definitely. All right. Well, without further ado, let's dive into the case. So, Parissa, thank you so much for scribing. And Kirtan, you can go ahead and jump into the first aliquot.
Perfect, sure. So as I always do, and I'm sure Dr. Dhaliwal knows it, that in all the NEJM CPC cases, there is a tricky title. So I always come up with the title so that it's more interesting. So the title for today's case will be The Peril in the Matrix. So the first aliquot we have the chief complaint of severe vomiting and headache. And talking about HPI, we have a 60-year-old, very pleasant lady. And this is how the story unfolded. She presented first in the month of June with right-sided weakness and right-sided swaying. And she was outside the TPA window by the time she came to the hospital, so she never got any interventions. She was subsequently sent to the rehab. It was thought that she probably had some kind of stroke at that time. She was unable to regain the substantial strength, and that resulted in recurrent falls. And she also had some speech deficits because of this cerebrovascular event. This was in June. Now she comes back in October, and it was around mid-October, and she came with severe headache, nausea, vomiting, and at outside hospital, she was told that she probably has a bleed in the brain. And unfortunately, again, she was discharged from that hospital because of the lack of insurance. And now on November 1st, she comes to our hospital with recurrence of headache, and the pertinent vital signs were the high blood pressure of 174/90 in the ED. The CT was immediately obtained in the ED, which showed that there was small acute subdural hemorrhage over the left frontal lobe, prior infarct in the left anterior frontal lobe, with possible superimposed infarct in the left frontal lobe. And review of systems like no dizziness, vertigo, blurry vision, diplopia, hearing changes, tinnitus, abdominal pain, chest pain, shortness of breath, bowel or bladder disturbances. So I know it's a lot, but please feel free to ask any clarifying questions and I can answer them.
Okay, marvelous. Well, that's a terrific introduction. There's a lot to deal with. I am wondering about the peril and the metrics. I love cases that have a clue embedded, and I'll probably think about that as I go along. Let me start with the basic presentation, which someone came in with severe vomiting and headache. I think the association we sometimes may make will be that the two will travel together, but in real practice, they never do. What do I mean by that? The easy connection is actually to envision a story that happens here, that the headache is an intracerebral process, and that's why the person is there vomiting because of ICP. That is probably what is at play here. But if you take a step back in urgent care or in clinic, these two travel together for very different reasons. Oftentimes people are vomiting for any number of reasons, and then they feel unwell. And one of the ways people feel unwell is that headache syndromes are either triggered or induced, but it's a non-specific headache. It's not at all related to the GI ailment that is causing their troubles. And then there are some conditions that have the two that travel together. A great example would be something like migraine. Many patients' migraines, if they are severe, they are primary headache syndromes that have no space occupying aspect to them at all, but they have nausea as one of their accompanying features. Now, as you get to severity, that may change, but I just want to center ourselves that when you see this combination, they oftentimes are decoupled rather than shared by a common etiology. But in this case, I think the thing to sort out is exactly what happened to this patient, because we have very clear evidence that she's had multiple intracranial severe events / catastrophes. And I'm not sure exactly what the problem is that she's had. I think she may have had stroke or she may have had bleeding. But I think what's a certainty is that the later CT that's obtained by Kirtan and his team is that there is a subdural hematoma and there is evidence of prior and perhaps present infarction. So if I had to solve something, I'd start to ask myself, why does a 60-year-old have a stroke? And maybe that will retrospectively explain why there were strokes in the past. And the subdural hematoma is tricky. If there was trauma, that may give a ready explanation, or if she's been put on a blood thinner because of these previous strokes, that may explain it. So I'm going to put a pin in that, but just ask myself, why would someone of this age have a stroke? And it's not surprising that the two common mechanisms are usually going to be ischemic or thrombotic events, or it'll be thromboembolic events. There's many other ways that vascular blood supplies can be interrupted. They can happen through vasospasm. It can happen through in situ hypercoagulability. It can happen through dissections. It can happen through vascular bed inflammation or vasculitis and other forms of vasculopathy. But I wouldn't think that I have to think of those things in a 60-year-old, because if it is that she's had the misfortune of multiple strokes, I would spend a lot of my energy first trying to determine if it's been thrombotic or embolic, and go from there and leave those other things unreserved.
And Gurpreet, one additional question I had in addition to your brilliant breakdown of kind of causes of strokes and the teasing apart headache and vomiting is, what do you make of the fact that these headaches have been recurrent? Does the recurrent nature of these help in any way, or rather something that you're tracking? How do you think of their occurrence?
Yeah, I mean, the headache is tricky because I don't know the temporal relationship. Just this was such a complex unfolding. I don't know the temporal relationship of them. As a general rule, ischemic strokes cause headaches in a minority of patients, whereas space-occupying phenomenon, including intracerebral bleeds, frequently do. I don't know yet from Kirtan's story if her headaches and her ischemic events happen together. The approach to headaches is rather straightforward, which is that we usually try to figure out, is it one of the 3 or 4 common types of primary headaches, or is it one of the many intracranial processes that can unfold that are secondary headaches that are threats to brain or life? That's obviously things like infections and cancers and autoimmune processes and vascular phenomenon. But those tend to be, monophasic if they show up like bleeding, or slow and progressive the way an expanding cancer or infection would cause a problem. So I don't know what to do with it yet, because I don't know yet enough about her brain if the condition that's ultimately unfolding her brain also hurts. As an example, like you can have a headache like from giant cell arteritis, but that tends not to cause this sort of intraparenchymal ischemic process. So there'd be a mismatch in that.
All right, amazing discussion. Kirtan, back to you for the next hour.
Perfect. So first I wanted to clarify what Dr. Dhaliwal was alluding to, that what came first. And to be honest, we were also not sure. So firstly, the patient had language barrier. And because of all these recurrent events that patient was having, she unfortunately incurred substantial cognitive deficits. So she had aphasia, she had dysarthria, and she was not able to clearly articulate that what kind of headache she is having, when did the headache start, and how are they related to the stroke onset or not. So for the next aliquot, we have the past medical history. So she has hypertension and she is taking amlodipine for that. Since the first event in June, she has also been on aspirin and atorvastatin. Regarding social history, no alcohols, drugs, or cannabis abuse. Family history is unremarkable. Regarding the examination, so vitals were fine within the normal range. General examination, she was alert and oriented to person and place, but not to the time. And this was her baseline since last 2 months. Pupils were round, reactive and equal. Cranial nerves examination was fine. There was mild dysarthria and expressive aphasia noted. There was power deficits in the right side of the body. So right upper and right lower extremity power was 1 out of 5. Everywhere else, it was 5 out of 5. Reflexes were all right. Plantars were down going bilaterally. Sensory examination was also normal. And cerebral examination was also unremarkable. Gait was also all right. Some basic labs. So patient's hemoglobin was 10.7 with MCV of 84. WBC of 4.6 with normal differential. Platelets of 80,000. And unfortunately, we don't have baseline of any of these labs. So this is only one set of labs that we have. BUN, creatinine, AST, ALT, albumin, lights, magnesium, calcium, and LDH were within the normal limits. And in the next aliquot, I will reveal the imaging findings.
Okay. Let me just study this myself, and I'd advise others to do the same. And Kirtan, can I, just so I understand the time frame, then there's been 2 ischemic episodes, let us say the first one in June, and then one other recurrent event when she came to your facility, or were there other interval ones in between?
So no, the first one in June, and then in the October, she had this nausea and vomiting, but no stroke as far as we know from the outside records. And then when she came to us in November, she probably had another stroke as evidence from the CT scan. And MRI findings will clarify and corroborate the same later.
Okay, fair. So maybe there's been 3 events. I think one of the things to think about, a stroke can be sort of a misfortune that comes from a confluence of things like the new onset of AFib or atherosclerotic disease finally taking its toll. What might be unusual is to go to age 60 and have no strokes, or for that matter, any cardiovascular disease, and then all of a sudden get 3 episodic events in the course of a couple months. So you start to get the sense, you start to ask yourself what disease could have unfolded at that age and then unfolded in a rather explosive sense, right? That that it would strike someone down on an every other month rotation. You start to think about things that can do that. The categories of disease might be things like infections. Are we dealing with endocarditis, just as an example, that is firing off emboli? Does the person have an arrhythmia that's developed? And all of this would be really bad luck. Is it AFib sort of sending off emboli in multiple directions also from the heart? Is it possible that there's been a change in the state of her blood? An example would be if she's developed primary or secondary antiphospholipid syndrome. Some things like the low platelets might be a soft clue to that, or maybe there's even something more sinister, like a cancer that's developed that's made her particularly hypercoagulable. But as I'm trying to figure out sort of what is the distribution of brain injury that she's had, I'm more interested to figure out what sort of disease she has that would unfold at this pace. I won't belabor the approach to thrombocytopenia too much because I don't think it's explanatory yet here, but usually those are problems of impaired production, typically arising in the marrow, increased consumption, which can be in the periphery, anything from something like a microangiopathic process to antibody-mediated clearance, or sequestration that might happen if someone has hypersplenism or splenomegaly. And so in some ways, because the thrombocytopenia is the only hook we have outside of the CNS, you can't help but try to wonder, could there be something in each one of those categories that's responsible for her symptoms? But I think examining these cytopenias may be the first place to start, and oftentimes for that, a blood smear is the most important. Her anemia shouldn't be overlooked either, and that warrants a full evaluation as well, because we can start beginning the exercise of asking why people might have combined anemia and thrombocytopenia. But maybe I will come back to that once we learn more about the next round of tests.
And one question I have before Kirtan's next aliquot is, Kirtan already told us that we will get imaging, but just for kind of for the learning of everyone listening, could you tell us a little bit how you think about the threshold for imaging in a patient with a headache? What are some of the reasons why you would get imaging of the head? When would you not get imaging of the head for a patient with a headache?
Yeah, the American Association of Neurology issued guidelines on when people should have imaging for headaches. And some of them are things that may be easy to derive. I think as a simple sense, when they don't fit the primary headache syndromes is when we should start thinking about getting imaging, right? If they do not have the typical phenotype of a migraine headache, cluster headache, or a tension headache, that alone is probably reason to start thinking about it. Things that have been lasting for a long time, things that are escalating, things that come with the company of systemic problems like nausea and vomiting, and then of course focal findings on the neuro exam. All of those collectively are reasons to think about getting imaging. When we do and what we do is, a little bit of dealer's choice. Some things that sound very primary headache, like if we're not making progress with the treatment, so failures of management start to make us re-question our diagnosis. That's another reason. I've called someone a migraine headache, but after 3 or 4 visits, they're not responding. So that's another reason that we sometimes get it. In this case, the only reason that I would think a CT would be helpful, given this long and sort of stuttering history, is to make sure today a new bleed isn't unfolding. Otherwise, the resolution of the MRI will be particularly helpful. And not only does the MRI capture things like the parenchyma that we're interested in, it might also capture structures that we're not thinking about, for instance, like the meninges and other sort of extra-axial or extra cortical structures that could cause headache.
All right, amazing. Well, Kirtan, what did the imaging show?
Sure. So I have 2 images that I will share with you. And first I will let you guys interpret it, and then I can also give the official interpretation. So this is the first set of image.
So I will just say I can't keep track MRIs at all, like flares and Fiesta and T2 and T1, nothing of the sort. I sort of just have an idea in my mind of like where things should be one color and when they're not. And my sense is all of the white in the periphery is unexpected and may map on to the subdural that we heard about, but I even issue that with caution. I'd have much more confidence interpreting a CT scan.
No, I think that is perfect, Dr. Dhaliwal, that there was concern that all these intensities which we are seeing at the periphery in the parietal cortex and in the occipital cortex probably represents a subdural hemorrhage. And another striking findings is, friends, if you look at the thickness of the meninges. So like there is skull as the outside layer, then in between the brain parenchyma and skull, you can see this thick rim of the tissue itself. So it looks like that the whole meninges itself, they are thick. And you can see that there is some intensities like T2 intensities going through the meninges as well. So we can say that it is pachymeningeal enhancement. And I will share the official report as well.
But I think
And
that pachymeningitis is important because when we think of the different compartments in the CNS, again, I was alluding to what are the valuable things that you get from an MRI, and one of them is that it has a strength in imaging the meninges, which is not relevant so much for acute headaches, but is helpful for chronic ones, is the type of diseases that unfold in the meninges and the pachymeninges, particularly, oftentimes are the autoimmune and neoplastic variety, which just seeing that thickening allows us to at least think in that category, which was not one of our first thoughts coming out of the gates. This is in a distinction to a lot of subarachnoid processes that might happen, like bleeding and infection.
sure, perfect. And then for the second image, which is also like equally astonishing, this is the second image.
I'm trying to see if there's new information on this because the astonishment was astonishment is a great lead-in.
Yeah, I think apart from the meningeal part, if you like look at the cerebellar tonsillar part, it is like a little bit down than where it should be. So it kind of like a little bit of tonsillar descent. And now I can give the official MRI findings. It's like there are so many findings, and I will try to copy paste everything in the chat as well. So first things that radiologist noted was presence of bilateral hemispheric subdural collections with signal changes consistent with blood products, encephalomalacia extending along the left superior frontal gyrus and white matter gliosis, old caudate infarct and chronic microvascular ischemia. Ventricles were normal in caliber without any midline shift. There was diffuse pachymeningeal thickening and enhancement along the cerebral convexities bilaterally. There is sagging of the brainstem and cerebellar tonsillar ectopia, with cerebellar tonsils extending approximately 15 millimeters below the foramen magnum. And constellation of findings as above, including bilateral subdural effusions, subdural hematomas, diffuse pachymeningeal thickening, basilar cistern effacement, and cerebellar herniation, is highly suggestive of sequelae of intracranial hypotension.
And Gurpreet, I know that we got just a lot of information right now with the imaging findings. I thought maybe a helpful place to start, and what I'm really curious of is how are you framing the problem in your mind right now? What is the problem in your mind that you're trying to solve?
Yeah, I think in some ways they are unchanged. That is that there's a diffuse ischemia. There's and I'd say like there's diffuse ischemia or that needs to be described explained. Although I don't want to make sure I don't want to overstate that I know the mechanism of all these interparenchymal abnormalities, but I think they are ischemic changes, some of which are not progressive, like encephalomalacia. And then there's also this, I think, constellation of phenomena I'll put together, which is that the meninges are thickened, there's subdural bleeding that's happening, and there's downward herniation of the brainstem and the cerebellum. You know, when that latter thing happens in isolation, there are malformations called Chiari malformations that are explained by that, but they don't come with all the other company that this keeps. I think we have models in our mind of when people have low intracranial hypotension, and they're the one that we sometimes are responsible for is after a lumbar puncture. So when there's a reduction in CSF, but people can have spontaneous intracranial hypotension, which happens not from a procedure, but just from some dural rent that develops. Oftentimes they have some form of connective tissue disease that we can't really characterize. But on account of that, they have a syndrome where they have no headache when they're recumbent, but every time they're upright, on account, we think, of sort of the downward displacement of the brain and the setting of low CSF, you get headache that comes perhaps from the tugging on the dura, But that tugging, if you think of it in a very physical way, sometimes is also responsible, I believe, for bleeding because the bridging veins in the brain get pulled and yanked and are susceptible, particularly in the setting of trauma, for bleeding. So it may be that there is a story of low CSF, that's the intracranial hypotension, and we have to figure out why that is the case. That may also, I will just add, that repeated irritation, sometimes you'll see after an LP, people get pachymeningeal enhancement. That's why sometimes we have complex headache cases, neurology will say, yes, we want the LP and we want you to do it, but don't do it before you get the MRI, because after the LP, the meninges may be inflamed just by that procedure itself. So I have the challenge here of now trying to figure out if the enhancement of the pachymeninges or pachymeningitis that we see there is a signal for the underlying unifying disease that's responsible for this. Like, is this entire thing an ANCA vasculitis, for instance, that may account for this entire constellation of symptoms? Or is that simply a signal that just is part of the story of intracranial hypotension? And the real answer to this case is figuring out why there's intracranial hypotension. However, if I did find an answer to that, I'm not sure it would explain why there's so much parenchymal disease. So I'm sort of navigating those three things simultaneously.
Yeah, and exactly as you said, trying to figure out kind of the relationship between the pachymeningeal enhancement and the intracranial hypotension. How would you try to make additional progress in this case, given that we have these MRI findings and some basic labs? What would you want to do next?
Yeah, I think for the I think I'd have to separate them out when I can't unify, then I have to separate them out. So as an example, if I was wondering about, does this person have spontaneous intracranial hypotension, there's two lines of work we do. One would be a bedside test and just find out when they lay down, does their headache go away? And the positionality of that would help me say, well, maybe the headache maps onto there and I don't have to tie it into the ischemic process. The second thing is that you would go back and at least start to examine the possibility, is there any connective tissue disease? So when we find this, sometimes they're not defined connective tissue disease, but they have things in the playbook of other connective tissue disease, like they're elements of Marfan's in them or their family, or they're elements of Ehlers-Danlos in them or their family. And you might start to ask some of the questions specifically around that. Eventually, I probably need a specialist to sort through, but that's how I would try to build the case for why this person may have spontaneous intracranial hypotension.
All right, brilliant discussion so far, Gurpreet. Kirshan, what happened next in the case?
Yes, sure. So at this point in time, what happened was we were trying to figure out what Dr. Dhaliwal was saying, that can we figure out that why this patient has intracranial hypotension, and most importantly, can we fix it? Because this patient keeps on getting headaches, which are very bad and which are not responsive to medications. So we were trying to figure out what's going on. So whenever we diagnose somebody with spontaneous intracranial hypotension, we do a procedure known as myelogram. So basically we inject the contrast, and that contrast will go through the CSF and that will map the pathway of CSF, hoping that it will show a leak somewhere where we can fix it. So we did the CT myelogram, and unfortunately it didn't show any leak, but it did show that there were multiple meningeal diverticulars noted at the level of thoracic and lumbar spinal cord. Now that we were not able to find a particular leak, the pain service and neurosurgery recommended that often in such conditions we can do the blind epidural blood patches, like just hoping that we will catch the subtle leak, which imaging didn't show, but there might be a leak. So they did the 2 patches of epidural blood in the thoracic and lumbar region, following which her headaches improved a little bit, but she was still encephalopathic and she would keep on coming out of it and then going into it. So she was intermittently encephalopathic. And at this point in time, given that the patient had thrombocytopenia and we were not able to get a good sense of why she has all these features, the team decided to obtain the whole body imaging. So the CT chest, abdomen, pelvis was obtained, which showed that patient had multiple thyroid nodules, the largest one being 2.6 centimeter in dimension. The patient also had diffuse lymphadenopathy, classically in the left subpectoral region, axillary region, mediastinal, and hilar lymphadenopathy. There was no evidence of organomegaly. And that's the end of this aliquot.
Okay. So I'll let me comment on some of the things. So it's absolutely right that, first of all, I never knew there was such a thing as a meningeal diverticulum. I guess it's always possible that any part of the body can herniate or weaken. And I think I would work under the same assumption that that's a marker that there's some connective tissue weakness that exists in that connective tissue. And that is exactly right, that we try blind blood patches, which sometimes I've seen work very well. They've been very effective, and it's sort of a hope that it lands in the right place. And this patient, Kirtan, just to confirm, it sounds like it was moderately effective, right? It had some mild relief for the headache, but not.
Yeah, not entirely.
Okay. Which it tells us two or three things. Either it didn't take, it's a bit of a hopeful procedure rather than a targeted one, or if it was effective, that there's more to this headache than just the low intracranial process. Those are two ways to think about it. And the headache is residing somewhere else, for instance, in the process that's inflaming or infiltrating the pachymeninges. So take it as it were. I think like we've done most of the things that can be done, which is the spinal imaging, the empiric treatment. The one thing, Kirtan, I might add just to close that out, was there positionality to her headache or no?
So since she was aphasic, she was not able to tell us. We are not able
Yeah.
to figure out, yeah.
So it is possible that we may be sort of reaching the limits of what we can know about this headache, at least for the time being. It's not that we abandon it, but we sort of shift our attention anywhere. The other thing that you start to see here is one of the common processes that we do, or practices we do, when there's a problem in the brain. And that is, we think as hard as we can. We image, we lumbar puncture, which you may hold off on this time. We consult people, but at some point you have to find evidence or support outside the brain. People are loath to biopsy the brain. There's almost so many things you can do by staring at that 3 pounds of jelly and saying, this is what I think is going on. And they have to avert their gaze elsewhere. And I think when we do that, we do find ourselves in positions like this, where we say, let's see what's going on in the rest of the body. If I can find it, I can either map it onto the brain, or I can solve it outside the body and then say, is it conceivable it unfolds in the brain? There's two critical things that are found here. One is multiple thyroid nodules, and one is diffuse and substantial lymphadenopathy. The multiple thyroid nodules is tempting only in one direction. It's very possible that someone just has multiple thyroid nodules, because that's a very common, if you image people have all sorts of hypertrophic nodules. They may have autoimmune disease that lends themselves to nodularity. But it is rare that that's responsible for a systemic disease. With the rare exception of whether one or more than one of them represents thyroid cancer. And if it's so, then usually there's local lymphadenopathy that's spread from metastatic disease and beyond. An equally plausible situation is that the core disease is in that diffuse lymphadenopathy, and the multiple thyroid nodules are incidental. And for the time being, I am going to separate them, because I bet statistically that's more likely what you're apt to see. So then it gets us to how we approach lymphadenopathy. We have a job to figure out what beds lymphadenopathy is in. That's by exam and imaging. Then we have to go through the exercise of deciding which category of disease is responsible for it. And if it's anything more than transient, which I think the size and distribution suggests here, we usually go through the exercise of trying to figure out, are infections responsible, which are typically viral, mycobacterial, or fungal. And all of those can have targeted testing without biopsying. Is it a cancer, the cancer that originates in lymphoid tissue, like a lymphoma, or rarely a metastatic tissue to all those spots if we discover a primary? Or is it autoimmune? And autoimmune we've been thinking about in this case, but it's worth noting that not a lot of autoimmune diseases have lymphadenopathy as a salient feature of them. Lupus, for instance, can sometimes cause diffuse lymphadenopathy. Sarcoids sometimes can do that. But for the autoimmune activation that comes with many of those diseases, it's actually not that common that they present with autoimmune or diffuse lymphadenopathy. Every disease will have it listed if you look it up in UpToDate or something. But what is common is it's not so characteristic of autoimmune diseases to do that. In the end, if we find that's what this is, it'll be fine to retrospectively explain that. So I think our next step is to decide if the answer conceivably lies there after we do basic testing for some of those infections that I mentioned, and perhaps some of the autoimmune diseases. Do we sample that with an excisional biopsy to get an understanding of what it is? And remember, we still have a simpler test to be done here, which is examining the blood smear and working up those cytopenias as well.
Brilliant. I love how you really balanced, not necessarily combining every single finding into the dominant problem you're solving, but really highlighting that, some things potentially could be incidental, like perhaps the thyroid nodules, if that's what it turns out to be. All right, Kirtan, what happened next?
Perfect. So the next set of tests were obtained. So firstly, during the course of hospitalization, patients' blood counts keep on declining. So she eventually ended up having pancytopenia with nadir WBC count of 1.5, hemoglobin of 7, and platelets of 35,000. Peripheral smear was obtained and it was unremarkable. There was no evidence of cystocytes or spherocytes. Patient's reticulocyte count was on the lower side. It was like, I guess, 2. The corrected reticulocyte count. Patient's LDH was slightly elevated at 350. Bilirubin, as I said earlier, was fine. Haptoglobin was also within the normal limits. And regarding the coags, patient's PT, INR, and fibrinogen were within the normal range, but APTT was elevated at 59. Patient's ESR was elevated at 140. CRP was slightly elevated at 2. TSH and T4 were obtained because of these thyroid nodules. They were within the normal limits. And HIV test along with syphilis test was unremarkable. And that's the end of this aliquot.
Again, lots to process, but I think this is a complex case, so I understand. The thyroid testing is continuing, making me keep that on the sideline, and my attention is now turning to the bone marrow, right? The transformation from a bicytopenia that was mild to a pancytopenia that's severe means that the approach to pancytopenia may provide the answer. Again, it's about as broad a differential as you can get with lymphadenopathy, but we oftentimes think in terms of elements that are needed to produce or elements that the marrow needs to produce things effectively. As I think through this, I just ask myself in plain terms, you could send some blood tests like B12 and HIV and EBV, and I think they may be for style points because we don't have a huge pretest probability for them, although HIV is obviously instrumental in a case like this. But it seems like a foregone conclusion that we will want to get a bone marrow to find out exactly what's happening there. The low reticulocyte count, if I remember it correctly, suggests that we're already dealing with a hypoproliferative state. And the question only is, what is it in the marrow? Is it anything from an infiltrating malignancy to a granulomatous process to an infection that's unsuspected, or maybe even an autoimmune attack like aplastic anemia that we can only discover expediently by biopsying the marrow directly? That's not a full discussion of pancytopenia, but I think it is where my mind is at, unless some blood test gives us a quick and compelling explanation for what might be happening. Let me just make sure there wasn't any other new information. These are it's quite information rich aliquot. Oh, I'm sorry, HIV was negative, so we already confirmed that fact. And then I guess two other things I'll mention: the elevated PTT. Every one of these things warrants a thorough evaluation. So in some sense, we have an obligation to make sure that this is not an acquired factor inhibitor. If it is, it would give us some sense that the person's immune system has been activated, but we ask the same question again: is it an autoimmune process, or is it a malignancy like lymphoma that's elaborating the autoimmune process? At this age, the most common acquired inhibitor would be an anti-factor VIII antibody. And if she's later shown to have a process like lymphoma, I think that's what I would describe. Another possibility which came out at the very beginning of this and now is rearing its head again is if antiphospholipid is present that has elevated APTT as one of its signatures. But as soon as we make that diagnosis, the next question we have to answer is the same, which is why. And you can't assign someone primary APS until you've excluded all the underlying things that may trigger that, whether that's lupus or lymphoma. So talking a little bit in circles, but that's because every twist and turn sort of shifts our focus, but drops us with the same massive differential diagnosis. And I think that's what makes this a great case.
And if I could ask one question before Kirtan gives us the next aliquot. This is a little bit kind of outside the case, but I think it's appropriate now. My question is, when you have so many abnormal findings here, we have the abnormal findings on imaging, the cytopenias that progress to pancytopenia, the lymphadenopathy. How do you find, when you're dealing with a case that's so information rich, how do you kind of prioritize these different abnormalities in your mind and keep track of everything? What strategies do you use there?
Yeah, that's a fair question. It's a bit of a cognitive load in this case, so it's a good time to discuss it. I think in general, when you have lots of abnormalities, probably 2 or 3 things influence how much time you spend on them. One is experience, like how often does pursuing X abnormality lead to an answer, right? So like if you were to say, how often does chasing down the TSH of 6 solve mystery multi-system case, very rare, versus how often does chasing down pancytopenia solve a multi-system case? So that's one metric you use. I think the second metric that you may use is severity. So the more severe the lab abnormality is, the more likely it is that it's going to be explanatory. It's going to be signal rather than noise. And then third, it's probably what the brain does is like, if it can find an easy solution, it keeps pursuing it. So in some sense, I can envision many ways which pancytopenia is explained by a disease that explains this whole syndrome, like lymphoma, just as an example. And so you wind up sticking with it because you can see an end explanation. Whereas if there's some finding where you're like, I don't know how, like figuring out dysarthria would answer this question, you don't pursue it any further. It's probably more complicated what the brain does to decide what things it latches onto. Also, I would say if it sees patterns, so if you start to see patterns together and you're like, these things fit, then you start to say, those are the conditions I'm going to follow. Because you're absolutely right. There's no way for the brain to track all of these things.
Well, you're doing an amazing job tracking all of these things. So, Kirtan, let's hear what happens next.
Perfect. So this is the final piece of information that I will give before I reveal the final answer. So given the fact that patient had elevated APTT, cytopenias, and as Dr. Dhaliwal was saying, that all of this could map to some sort of hematologic malignancies as well. So patient underwent bone marrow biopsy, which was unremarkable. It showed tri-lineage hematopoiesis without evidence of hemophagocytosis or granulomatous infiltration and no evidence of fibrosis. The lymph node was obtained and lymph node showed preserved architecture and reactive changes. On staining, the IgG4 cells were slightly elevated, but they still didn't fit the criteria for IgG4 related diseases. And finally, for APTT workup, the antiphospholipid antibodies were obtained and they were positive. And all three of them were positive: cardiolipin, beta-2-glycoprotein, and lupus anticoagulant. And this is the point where the case ends. And then I can ask you to have the final discussion and tell us that what's the final test you want to do and how we will close this case.
Okay, fair enough. Yeah, let me think through this. I want to confirm the antiphospholipid antibody testing is important. So you said the entire parameter was positive. Is that right?
Yeah, correct. All three of them were positive.
Okay. So I think, as I think out loud, I think some of the things we have to decide is what is true and what is so unique and definitive that you think it must be explained, right? And as I go through this case, I think there's a series, there's a rapid onset of multiple infarcts of the brain that are probably disproportionate to just having hypertension on one drug. So I think that phenomenon needs to be explained. There's a profound pancytopenia that did not localize to the bone marrow. That also needs to be explained. And it's a bit tricky because I think there's other elements that seem like it might be hypoproliferative, namely that smear and that, if I remember correctly, a low reticulocyte count. There is a profile of the antiphospholipid antibodies. This is tricky. Technically, the condition, it requires a separation in time and space. That's to say that the antibodies have been proven to be persistent rather than just transient, because a lot of things can cause transient elevation. Even CRP itself, CRP actually interferes with the phospholipid assay. So CRP's presence is something that causes a false positive. But if there were three, I'm sorry, I lost the antibodies there, but there was anticardiolipin, beta-2-glycoprotein, and something else.
Lupus anticoagulant. All three of them were positive.
Positive. It gives the sense, and depending on the titer and which immunoglobulin was there, that is truly elevated. And then there is diffuse lymphadenopathy. And as I write these out, you ask, or at least I ask myself, I say, if it is true that it is behaving in one way, that is to say that it's that the antiphospholipid antibody syndrome has been elaborated, is that a sufficient thing? Is this primary antiphospholipid antibody syndrome? And I think the answer to that has to be no, because in essence, what that means is that there's no underlying condition that's responsible, and there's too much multi-organ disease to signify that these antibodies are elaborated alone. I think if I was trying to ask myself what other condition could cause pancytopenia, lymphadenopathy, and perhaps profound ischemia on its own, I think two things that are precipitants of antiphospholipid syndrome that could do that would be a lymphoma, which there's many types to be defined, or the presence of SLE. And I guess I should take each of them in time. SLE would be conceivable in this patient. You know, there's 11 criteria. We don't deal with them rigidly. Instead, what we ask ourselves is like, is there enough signature in enough organs, whether that's the skin, the brain, the kidneys, and the bone marrow to say that this disease is present. We didn't get evidence of the kidney having abnormality in Kirtan. I'll presume that's the case, that there was none there.
Yeah. Kidneys were fine.
Kidneys were fine, which is not essential in lupus, but oftentimes it's very characteristic of the profound disorder. And so for that reason, I would, and this sort of explosive onset, I might say that's less typical to have SLE, but you know, I've certainly sent an ANA for far less. So if that wasn't sent, I would send that now. Did I miss that, or was an ANA sent for Leon?
Not yet.
Okay. And then the other thing, which if I was to be honest, I think is a bit more compelling, is the idea that there might be a lymphoma. And the reason that is compelling, I think, is the degree of lymphadenopathy and the extent of it. The only thing I think that really argues against that is that we can't find the lymphoma anywhere. And when you can't find the lymphoma anywhere, but you think someone is acting like it, you have to wonder if there's variants of lymphoma that sometimes live in only isolated compartments. And one of the ones that comes to mind is the idea of intravascular lymphoma. So intravascular lymphoma is a B-cell lymphoma. It almost exclusively lives in the intravascular space, and it takes a great toll on the brain above all places. I think one counterpoint against it is they oftentimes have spectacularly high LDHs. So when there's intravascular lymphoma and it's lining the vasculature, oftentimes LDHs are well above 1,000, and this is a rather modest elevation but it does take a toll on the brain like this. So it could be the intravascular lymphoma or the APS that I believe is associated with that could account for her recurrent falls. But I got to say, one thing that I think is probably a weakness in both of those hypotheses, if I was honest, was why those meninges are so inflamed. Like that pachymeningitis was very, very impressive. And it is possible that either one of those processes is unfolding. That is to say that she has lymphoma, and the lymphoma is also showing up in the brain, the so-called lymphomatous meningitis, and that's responsible for the enhancement of the pachymeninges. It's very rare for carcinomatous meningitis to appear without a known primary, but hematologic malignancies can land there. Or that the pachymeningitis that she has is autoimmune in nature. And although I associate that more with diseases like ANCA, positive vasculitides, and IgG4, I suspect it's conceivable that SLE would do so as well. So what would I do in this situation? You know, I think there's some core things you do, like you would revisit the pathology with the pathologist, because you have tissue that you elaborate, make sure there is no signature of lymphoma that we can see in those places. I think you could entertain an LP. It would be done with peril because of this downward herniation that's going on, but the presence of malignant cells and CSF cytology would really skew the calculus in that direction. And I think sending an ANA and an ANCA would be plausible or good next steps to take in this case as well. Let me think through if there's any other. Yeah, I think that is where I would be at this point in the case. I don't know if there's any other input from the chat that I've missed or that would be helpful, or insights I should respond to, Maddie, before we hear the conclusion.
No, I think I'm a really beautiful dissection of kind of your two leading hypotheses on lymphoma and lupus. I'm curious, I guess, anything else you would do to try to make progress between those two? You mentioned kind of the ANA for lupus. Is there any other, I guess, advice you have about trying to tease those two apart in a case like this?
Yeah, I mean, we put so much weight on the ANA being, you know, positive or negative ANA, particularly if it's spectacularly high, really would shift the equation towards SLE. So I think doing that, and then in terms of the lymphomas that are sometimes difficult to find and locate, the test for intravascular lymphoma, although I don't find it to be a perfect fit, is to do a deep skin biopsy and look for it in the look for the enhancement or so the presence of B cells inside the vessels themselves. I don't, to the best of my knowledge, I don't think biopsy, brain biopsy or meninges biopsy is done easily, but it's possible that the answer lies there as well. And maybe I'll ask Kirtan before he gives us the answer, which one of those things was sort of in the ballpark of how they were thinking about the case, and which ones, without necessarily revealing, but can you help narrate how those things were thought through before we get the answer?
Yeah, I think I agree with you, Dr. Dhaliwal, that you guys got it. That we are also thinking that maybe there could be lymphoma, and we know that even SLE can cause secondary lymphoma. There is a strong association between SLE and non-Hodgkin's lymphoma. But we were also thinking that the strokes are not fitting the pattern of intravascular lymphoma, because you would expect like more small vessel strokes rather than the large strokes that we were seeing. And also the LDH part, as you mentioned, that it's unusual that why the LDH is not so crazy high. And we also know that pancytopenia is not something which is common in intravascular lymphoma, because intravascular lymphoma doesn't go to bone marrow, but it can trigger HLH for sure. That's why we did a bone marrow biopsy, hoping that it would show hemophagocytosis and can tie in the hypothesis of intravascular lymphoma causing pancytopenia, but that also didn't pan out. So I guess what you discussed is perfectly what we were also thinking.
And I appreciate that point. I think, yeah, it's interesting. Sometimes I saw someone on Twitter saying recently, which I thought was a great observation, which is HLH is like diagnosed so widely, but it's oftentimes not the destination diagnosis. It's that phenomenon. All the things you see in HLH existed before people had the disease called HLH, and it was just when lymphomas and SLE and other conditions had very, very severe end-stage manifestations, and we had a name for it, and I think it's been helpful, but it still begs the question, if you found those, which of those core diseases is responsible here. And while I like lymphoma, I think the inability to find it is telling, and also the thickening of the pachymeninges, I think it just maps a little more onto inflammatory disease, but I can't say with the frequency with which that is done. So I would not mind revisiting the biopsy. And I guess maybe the last thing is worth saying is the marrow not showing anything, like the lymphoma, if it was to cause such a profound cytopenia, yet not being there, not just to the point about intravascular doesn't go there, but there is no lymphoma there. If we look for it, is you have to invoke what else happened. Is it just a generalized immune suppression, NOS? And maybe that's where we'd land if we find a cancer elsewhere. But all those things tip me in the favor of an inflammatory condition, but I wouldn't say with great certainty.
Kirtan, what happened? What did your
Perfect. So
team think of the case?
awesome. So like you guys got the answer first, let me tell you that. And now secondly, this is like very fun part about medicine, that if we have the same problem and if we are dealing with in a different way, let's say I am the first-hand physician treating this case versus I am, let's say, in the position of Dr. Dhaliwal, where I'm just discussing this case as a third person, or secondly, I'm reading this case in journal. Like if we like do the analysis, like in all three cases, the same person would come up with different answers, because we have different approaches, we have different mental models of how we approach the problem. So same thing happened to this patient, that if we take a step back, things start making sense. But when you are in the midst of it, there are so many things going on. Like the patient is in neuro ICU for like weeks and weeks, patient is not improving. So it's crazy. So this is how things turned out, that one of my friends was in ICU and she texted me that, Kirtan, we have this interesting neuro case, maybe you would be interested in it. So I was like, yeah, sure, why not? So I went down, I take a look at the patient and looking at their profile. And the first thing I figured out is that, okay, this patient has headaches, this patient has subdural blood collections, all of which could be explained by intracranial hypotension. Now, the point which Dr. Dhaliwal was mentioning was so important, is that if you look at the classic radiologic findings of intracranial hypotension, diffuse pachymeningeal enhancement is the one classic feature. So the point becomes that, is that enhancement coming from the infiltration by IgG4, lupus, GPA, or is it just a sequel of low intracranial hypotension? And another point becomes that, let's say it is due to carcinoma, IgG4 or whatever, but do those diseases cause intracranial hypotension? Like, do they cause leak or not? So that was the dilemma which is important to figure out, that we might have an explanation for hypertrophic meninges, but can it explain the leak as well? And if not, then we are left with a single problem, that enhancement is just because of the hypotension and not due to a real pathology going on at the level of meninges. So basically, meninges are innocent bystander. That is what we were dealing with at that time. The second aspect was the strokes part. Now, intracranial hypotension doesn't cause strokes. So the question becomes that, why would this person have two rare findings of multifocal strokes in a span of 3 months and hypotension at the same time? And then, as Dr. Dhaliwal was saying, that, and even in the chat, like Andrew mentioned, that when you have thrombocytopenia and elevated APTT, you always got to think about APLS. And the stroke pattern which we found in our patient were consistent with APLS. So by the time I went there, APLS was there, these hypertension findings were there. And then I suggested the team that, hey guys, that this person has APLS and it's very unusual to have primary APLS unless you are like very young and you present with catastrophic APLS. So I said that, it could be secondary as well. And at that point in time, the patient already had CT scanning and we showed this lymphadenopathy. So as soon as they saw lymphadenopathy, everybody was in the panic mode, that they were like, this person has some sort of lymphoma, some sort of brain cancer, which has metastasized and now is wreaking the havoc on this person. So they went crazy. Like they went for bone marrow biopsy, flow cytometry, CSF cytology, everything. Everything was unremarkable. And then I suggested that, guys, we have not done the simple thing that, as you guys were suggesting, what about ANA? That what if this is secondary APLS from the lupus itself? And then finally, they got the ANA. So ANA was positive. It was like over 1:160. Anti-dsDNA was negative. Anti-Smith was positive. Anti-RNP was positive. Complements were undetectable. The UA was fine. No evidence of nephritis. And another subtle point which I told my team was that, guys, if you look at the ESR-CRP, now the ESR-CRP discordance, we can talk hours and hours about it. And, some experts agree on it, some experts don't agree on it. For example, you might have seen 1,000 patients in your life who have both ESR-CRP through the roof and they would have SLE. But then once in a while, you will find a patient who has very high ESR without any other compelling reason, and CRP would be like barely detectable. And this is one of the classic things which we see in lupus. And the reason is that the lupus is the disease which is characterized by interferon gamma signature. So whenever the levels of interferon gamma are high in your blood, as it is in case of lupus, it suppresses the production of CRP from the liver. So if you have like profoundly low CRP and very high ESR, then you should think that this might be lupus. So that is what I suggested to the ICU team, that, hey guys, your patient has his APLS and now there's this worsening of cytopenias and CRP is like barely elevated. We should think about lupus. And they are like that, yeah, you are right, Kirtan. Maybe we should have done that before we went all this lymph node biopsy and stuff, invasive things in a person who is in neuro ICU. And then eventually, when the lymph node came back and it was showed reactive changes and the ANA was positive, everything made sense that this person had lupus, and we know that lupus itself can cause strokes. That person had APLS, which can also cause strokes. And now coming to the juice of the case, that what about the title? So as you guys were alluding, that lupus is at its core a connective tissue disease. Like all these diseases which we think about, lupus, sarcoid, MCTD, they are connective tissue diseases. They affect collagen, elastins. It's just that we don't think about those manifestations enough, but they do cause that. And in fact, SLE is known to cause spontaneous intracranial hypotension by dural leaks. And now remember that this patient had meningeal diverticulars. We didn't identify the leak because it's very difficult to identify the leak given that contrast has to flow at a particular pace. It's just like, how we visualize the GI bleed. Sometimes angiography won't pick it up because it's not bleeding or something like that. Same way it happens to the CSF contrast as well. But the presence of meningeal diverticula in a relatively young person who doesn't have degenerative joint disease makes you wonder that this is due to the weakening of the dura. And maybe one of those diverticulars did leak at some point in time and then spontaneously healed, which is why you are not seeing it. So that is why the peril in the matrix, or like fire in the matrix, because there is so much inflammation in the dura mater because of the lupus itself, that you weaken the dura, you cause the leak, and that leak causes this hypotension, severe headaches, and coincidentally, this episode coincided with the stroke. That's why it confounded everything. And the best way to figure out if we are right or not is the treatment. So the patient was started on prednisone, hydroxychloroquine, and guess what? Like within 2 weeks, all the cell counts stabilized. 1 month later, the lymph node and everything resolved, like the repeat CT scan. And the MRI, which was repeated, showed there is no enhancement, no pachymeningeal enhancement, everything is fine. So it again proves that maybe that pachymeningeal thickening was solely due to the intracranial hypotension itself and not due to the infiltrative process. Because if it was lupus pachymeningitis, then usually it doesn't respond as good to like just 1 month of immunosuppression. It needs like intensive immunosuppression. So that was the final conclusion, that the patient had SLE with secondary APLS leading to dural weakening, causing spontaneous intracranial hypotension, multiple strokes. And you guys got it. So good job.
Well, I am absolutely speechless, Kirtan. That is truly such an amazing case to learn from. And thank you for so brilliantly presenting and teaching us all right now. I'm absolutely speechless. And Gurpreet, I know we're at the hour, so I want to be respectful of your time, but wanted to give you the space to reflect on what it was like discussing, and if you wanted to highlight, two teaching points for people listening.
Yeah, no, I learned a lot just in the course of that, was taking notes as we go. I think just because we're at the top of the hour, I might say, like, what is it that you could do to learn from this case, right? I think this was an exercise in holding multiple realities in your mind at the same time, right? You had to for instance, you had to hold in mind the idea that the pachymeningitis was just a secondary phenomenon of intracranial hypotension, but then you had to ask why the intracranial hypotension, or you had to hold in your mind the pachymeningitis was the clue, which I actually considered for a long time. And if it is, then you have to ask what disease would do it. But every time you tried to try everything together, eventually you would run into an arrow that doesn't point. You'd be like, okay, I figured all this out, but then why are there strokes? Or you might say, like, I figured out a beautiful explanation for why there's strokes, but why is there pancytopenia? And then, or you run into a dead end with something else. I think one of the ways to really test your knowledge is almost to try to replicate. Oftentimes we try to practice by drawing out schemas, but a case like this invites you to test your knowledge, which is how I'll take my notes on this case, by a chain of reasoning, which is essentially to start with SLE and say, with that, can I draw all of the arrows, like the connective tissue dimension of SLE, the cytopenia dimension of SLE, the parts of SLE that didn't show up, and see if you can draw a web? Because essentially there's 2 or 3 realities that you have to keep in your mind. And I think the way Kirtan tied it together at the end is the only acceptable and plausible one. APS was the bridge between the other effects of the lupus unfolding. And it's so interesting because it unfolded in the brain even in 2 ways. That the APS probably took its toll on the parenchyma, was the inflammation took its toll, it took its toll on this connective tissue disease, which then secondarily took its toll on the pachymeninges.
Yeah, it was quite inspiring to watch you hold all of these different realities in your mind, dissecting this case with so much information. So really quite impressive. And thank you so much for taking the time to teach us during this hour. I really appreciate it, Gurpreet. And Kirtan, as always, you are just so amazing. And I learned so much from your presentation and your teaching at the end. So thank you, thank you, thank you. And Parissa, thank you for scribing all of this information, and Kuchal for writing down the beautiful teaching points. And we will end the session here, but thank you all so much for coming, and a huge thank you to Gurpreet and Kirtan.
Thanks, everyone.
Kirtan and Gurpreet, please never make a podcast, or Ravi and I will be out of business. We beg you.
All right, that's a deal.
Bye, everyone.
Bye.